I thank the program convener, Dr. Rajeshwar, and the organizers and AstraZeneca for the opportunity. And it's an honor to share the stage with luminaries, including Dr. Vincent. I shall be talking on my experience and the experience of immune checkpoint inhibitors in stage 3 NSCLC, which is unresectable. We all know that lung cancer is the leading cause of cancer globally, and the mortality rates mirror the incidence rate, and it's a very dynamic disease. And most of the most of the cases of lung cancer found in Asia now compared to in North American and European continent, where we are seeing close to about 0.8 million versus 1.2 million cases in a year in the Asian continent. The burden of lung cancer in India, as per the 2021 fact sheet, shows that about 88,831 new incident cases were there, and almost 80,000 lung cancer deaths were there. Dr. Navneet has already covered the modified AGCC 8th edition staging, where we can see that those patients who have T4, N0, or N1 disease would fall in stage 3A, T3, N1, or a T1, T2 with an N2 would fall in stage 3A. The stage 4 would include a T3 or a T4 disease with N3 nodal station, and the rest would come in stage 3B in the intermediate. And the clinical and pathological survival rates would drop from 36 to 26 to 13% from stage 3A, 3B to 3C, which is pretty dismal. In a pictorial manner, we can see stage 3A, 3B, and 3C as I depicted, that as the tumor size is small, but at least an N2 size is there in 3A, or intermediately in a T3 or T4 with an N2 disease is depicted in the cartoon fashion. Globally, we see that the majority of patients are diagnosed in late stages. That's about 75% in stage 3 and 4, which are unresectable, and 25% would be resectable in good thoracic centers. They undergo surgery and they may become eligible for surgery. In India, fewer patients are diagnosed in earlier stages, and just about 3.5 to about 4% would come in stage 1 and 2 or would be resectable. Most of the patients we see in the real world are mostly in 3B or 4 and are much beyond operability. Also, those whom we see in stage 3A, which would have been operable, in India, surprisingly, they have a lot of comorbid illness, probably due to smoking or with COPD, they have emphysematous, or they have concurrent coronary artery disease, and hence become unsuitable for resectability. So we all know that 85% patients have non-small cell lung cancer, while about 15% have small cell. Out of the non-small cell lung cancer, about 1/3 roughly, or 25 to 40% have locally advanced disease. And 30% of these present with disease that is unresectable due to technical reasons. We all know the current treatment for stage 1 and 2 being surgery, followed by adjuvant radiotherapy, followed by adjuvant chemotherapy, or if a patient is ineligible for surgery by SBRT in stage 1 and 2. And we have also seen that stage 4 would require a double platinum agent therapy with or without immunotherapy, according to the performance status or supportive care. And today we're talking about stage 3 patients who have for whom concurrent chemoradiotherapy and consolidation immunotherapy is a new standard of care. So the management of stage 3 NSCLC requires a multidisciplinary team, with the core being the medical, surgical, and radiation oncologist, who have to be supported by a pulmonologist, a pathologist, and ideally a thoracic surgeon. The pre-treatment evaluation would require a pulmonary function test, bronchoscopy, and pathological imaging or pathological node sampling. A PET scan would be paramount, and a brain MRI with contrast would be required to look at brain metastasis. The treatment would, depending on the performance status, would include concurrent chemoradiation or sequential chemoradiation if the performance status is doubtful. So the unmet need in stage 3 NSCLCs, although while we give concurrent chemoradiotherapy with a curative intent, we only have about an 8 or 10 month PFS or a 15 to 20% survival, because 40% of them loco-regionally relapse with meds, and 50% would have distant meds despite this very intensive treatment in this particular population. So the evolution of treatment approaches has included either adding induction chemotherapy or adding consolidation chemotherapy or increasing the dose of radiotherapy, but these have not had any OS benefit at all. Now they are on, as of now there are many other studies going on where the radiotherapy dose has been increased from the earlier 54 to 60 grays, now 60 to 66 grays over 30 to 33 fractions is the standard of care for the thoracic RT. So improving outcomes in unresectable stage 3 NSCLC, other than a recent study showing an increasing the dose of the radiotherapy, which has now become the standard of care, like I mentioned, but increasing it beyond that to 74 grays in various other studies have not shown to have any OS benefit. In fact, they worsened the OS. So neither induction chemotherapy nor consolidation chemotherapy nor increasing the radiation dose is helping. There is no phase 3 consolidation therapy with targeted therapy or vaccine as of now, which has shown a PFS or OS benefit. But yes, there is a subset of group being shown in the LAURA trial, which is an ongoing study, which is using sequential osimertinib in EGFR mutated stage 3 NSCLC. So immunotherapy is now increasingly being recognized as the safe and current option for this subgroup. So this I've already mentioned, that the disease progresses very rapidly, hence a dismal OS. So now we come to the main crux of this talk, which is the Pacific trial. And as the wide ocean, there are various other Pacific trials, Pacific 2, Pacific 4, Pacific 6, which are all ongoing. But the Pacific trial study design was a phase 3 randomized, double-blind, placebo-controlled, multi-center international study, which included unresectable NSCLC who have not progressed following platinum doublets of at least 2 cycles given during concurrent chemoradiotherapy. They included patients who were 18 years or older with a good performance status of 0 and 1, and archive tissue was collected. They were all given subsequent durvalumab as consolidative therapy at least 6 weeks, within 6 weeks after concluding concurrent chemoradiotherapy. This was given in a dose of 10 milligrams per kg 2 weekly for a period of 12 months or 1 year only. And this was randomized in a 2:1 ratio with a placebo, and the primary endpoints being PFS and OS, and secondary endpoints being overall response rates, patient-related safety outcomes, and safety issues, and the durability of the response. The Pacific study was well matched for age, and the median age was 64 in both age groups of durvalumab and placebo as consolidated therapy. 70% were males, they were white, and 96% of patients had disease in stage 3, and they had an excellent performance status. It's also important to note that 6% had EGFR mutation. These patients were not matched in the pre-analyzed data for PDL1 status. So they were irrespective of the PDL expression that they got durvalumab, but also almost about 27% of them received induction chemotherapy prior to concurrent chemoradiotherapy. So the Pacific study included 711 patients finally who received concurrent CCRT, and out of these 191 had received induction chemotherapy. So the 5-year updated data showed that these patients had a definite survival advantage, and this was presented in ASCO, which showed a 42.9% of 5-year overall survival versus 33.4% for the placebo arm. The 5-year PFS data showed a 33, is a slide matching? Yeah. In the intent to treat population, it showed a significant PFS advantage of 33% versus 19%. And this also shows that the response it was a durable response, and the curves have separated very early in the course of treatment. and the sustained benefit of 5 years was shown. So in the durvalumab arm, the many patients after completing the treatment have received some kind of a platinum-based therapy, a single agent, double agent immunotherapy, or targeted therapy following the completion of the treatment, and 41% required this in the durvalumab arm versus 54% in the placebo arm. The patterns of progression, it is interesting to note that the extrathoracic disease was very well controlled with durvalumab, and the intrathoracic progression, the recurrence occurred locally. That means that we must look at increasing the loco-regional control either by, say, enhancing the techniques or making the radiation more conformal. It also reduced the time to death by 25.2 versus 9.2 months, which was very, very significant. And it also reduces the number of brain metastasis. So it has been hypothesized that probably the brain mets have been reduced because those patients who had metastasis in the brain were probably having leaky blood-brain barriers, and these immunotherapy molecules could modulate the tumor infiltrating lymphocytes which were present within the tumor in the CNS, which has been shown in other studies as well. The side effects were notable for...
Sir, sorry to interrupt. Kindly conclude your talk. We have only 2 minutes left.
Yes, I have the last slide. So basically grade 3 pneumonitis was present in about 3%, and pneumonitis was present overall and comparably in 33 versus 24%. And this was not a major reason for discontinuation of treatment. So there is hope for cure in stage 3 NSCLC, and the 5-year survival has never been as good as it has been shown. So the key takeaway would be that the 5-year overall survival of 42.9% has been achieved in the durvalumab arm compared to 33% in the placebo. And the patients had lower incidence of death, brain metastasis, and that pneumonitis was not a deterrent to giving durvalumab, which is not a very expensive treatment, especially in those institutes which can afford it. So I've finished. I'll be glad to take any questions if there are.